welcome back to this discussion on endocrine emergencies. And in this video, we're going to talk about some of the other emergencies associated with the endocrine system. One relatively common type of emergency is pancreatitis. Pancreatitis is inflammation of the pancreas. Acute pancreatitis is a medical emergency, and it can lead to dehydration and hypotension. There's a lot of vomiting associated with the symptoms. So the more somebody vomits, obviously, the more at risk for hypovolemia and dehydration they are. 60 to 80% of cases of acute pancreatitis are caused by gallstones or chronic alcohol abuse. It's very common to see pancreatitis associated with alcoholism. But there are some other potential causes that include certain medications, trauma, pancreatic cancer, or just a genetic predisposition. Chronic pancreatitis is a progressive disease, and this eventually leads to the loss of all endocrine and exocrine functions, often causes chronic pain, and it's diagnosed by CT, so computed tomography will actually be needed to diagnose a chronic pancreatitis. When it comes to assessing these patients, you should note that acute pancreatitis may present with a flank or an epigastric pain that worsens if they're laid flat or supine. They might actually have a tachycardia due to the dehydration. A fever is common with any type of inflammation, so of course with acute pancreatitis, they'll present with a fever, and even jaundice because this does affect the liver. Typically, an attack is a result of a large, heavy meal or excessive drinking, and the symptoms include nausea and vomiting, abdominal distension, or muscle spasms. Less frequently, necrosis or organ failure may actually occur. Laboratory diagnostics include determinations of serum amylase, lipase, and trypsin. And again, how I said it affects the liver, we know that the pancreas is not that far disconnected from the liver. You know, you have that common bile duct that comes on down and connects to the pancreatic duct right by the duodenum. And this is where a lot of the enzymes meet for digestion. But we also know that the pancreas will act on the liver via glucagon and insulin. So there's a lot of correlation between the two. They work synergistically. The pre-hospital management of pancreatitis is generally just supportive care, whether it be acute or chronic. They're going to get an IV O2, some monitoring. They should be transported, however, to a facility for better treatment, and if they have chronic pancreatitis, they might want to consider a lifestyle change. They may even need some type of surgery, and patients should be monitored for pancreatic cancer, whether they have an acute presentation, of course, chronic presentation. Next up, we have adrenal insufficiency. Adrenal insufficiency is characterized by the decreased function of the adrenal cortex and consequent underproduction of cortisol and aldosterone. It could result in weakness, dehydration, and the inability to maintain an adequate blood pressure. Cortisol's primary role is to assist in the response to stress, but it also could help maintain blood pressure and cardiovascular function. And cortisol regulates the metabolism of carbohydrates, proteins, and fats, and it even helps modulate glucose levels by balancing the effects of insulin. Cortisol also slows the inflammatory response, so it's got an important job. And when somebody's got adrenal insufficiency, they have an underproduction of cortisol and aldosterone. And we know aldosterone helps maintain blood pressure as well by stopping the elimination of sodium. This adrenal insufficiency is usually well tolerated, but it may be complicated by other factors such as infection or stress. And it affects about 4 people out of every 100,000 in the United States. So Addison's disease is a type of adrenal insufficiency that's caused by atrophy or destruction of both of the adrenal glands, and it leads to a deficiency of all the steroid hormones that the adrenal glands produce. It's rather rare, about 1 per every 100,000 people in the United States, so a quarter of all the adrenal insufficiency patients have Addison's. Usually the result of idiopathic atrophy. An immune system creates antibodies that attack and destroy the adrenal cortex. It sees it as an invader for some reason. It occurs when at least 90% of the adrenal cortex has been destroyed, so the outer layer or shell of the adrenal glands, if you will. It's less commonly caused by tuberculosis or a bacterial, viral, or fungal infection, or even an adrenal hemorrhage, or a potential cancer of the adrenal glands. when you're assessing somebody that might have Addison's disease, they could be complaining of something like unexplained weight loss, fatigue, vomiting, diarrhea, anorexia. They'll have a craving for salt because they're hyponatremic, their sodium levels are going down. Muscle and joint pain, abdominal pain, postural dizziness. They could have an increased pigmentation in the extensor surfaces, palmar creases, and oral mucosa of the skin. So what happens with Addison's disease is the body improperly regulates sodium, potassium, and water within its body fluids. And blood volume and blood pressure will actually fall, and sodium concentrations, of course, will fall as well. So typically those they correlate. When sodium's up, your blood pressure will rise because volume's increased. So as sodium is decreased by the elimination of sodium, or the increased elimination of sodium, your blood pressure can then decrease as well. This causes your serum potassium level to rise because sodium and potassium can counterbalance each other. So when your sodium level is down, potassium, relatively will be higher. So your serum potassium level will be higher in these patients. Management of these patients is rather simple. You're going to manage, of course, the airway, breathing, and circulation as you do with all patients. And initiate aggressive fluid replacement using D5W if you've got it. And then in some protocols, they might allow for the treatment with hydrocortisone. About 100 milligrams IV is indicated in the acute management of an Addison's crisis. Secondary adrenal insufficiency is relatively common. It's characterized by a lack of adrenocorticotropic hormone, or ACTH, secretion from the pituitary gland. ACTH stimulates the adrenal cortex to manufacture and secrete cortisol, as we spoke about before. It may also occur in patients who abruptly stop taking corticosteroids. So corticosteroid treatments suppress natural cortical production. All right. So again, the secondary adrenal insufficiency is due to a lack of the ACTH secretion from the pituitary gland, not specifically the adrenal glands having any issues, but the pituitary gland isn't producing enough of that ACTH. And then you get a low amount of cortisol production. And again, cortisol helps regulate blood pressure, blood glucose, the digestion of fats, proteins, all of these things. Signs and symptoms typically appear more suddenly with an Addisonian crisis. It may be triggered by an acute exacerbation of chronic insufficiency, and its most common cause is a corticosteroid withdrawal. About 25% of patients first experience symptoms during an Addisonian crisis. The chief clinical manifestation is shock, all right? And then you're going to use your shock protocol to treat these patients. Symptoms will also include weakness, lethargy, confusion, loss of consciousness, low blood pressure, elevated temperature, severe pain in the lower back, legs, and abdomen, and then severe vomiting and diarrhea. The more severe the vomiting and diarrhea, the more likely they'll be hypovolemic. Again, fluid replenishment is always important with these patients. Management of secondary adrenal insufficiency is going to be very similar to the Addison management. You're going to treat the episode, maintaining ABCs, airway, breathing, circulation. Begin rehydrating the patient and correct electrolyte and acid-base abnormalities. This may have to be done in the hospital, but you're going to start an IV and infuse up to 1 liter of normal saline. And if the patient's hypotensive, administer continuous normal saline bolus is about 20 cc's per kilo. And then check the patient's glucose level, administer 25 grams of D50 if you've got it, or if your protocol tells you to administer D10 or some other concentration of dextrose to treat the hypoglycemia, then do that. D5W or D5 normal saline is the preferred IV fluid for these patients to administer dextrose as you're rehydrating them. And you're going to, of course, monitor the cardiac rhythm. Electrolyte abnormalities can cause pretty serious dysrhythmia, so you're going to want to maintain constant cardiac monitoring. Next up, we're going to talk about Cushing syndrome. And Cushing's is kind of like the opposite of Addison's. If you picture an excess cortisol production by the adrenal glands, that's more Cushing syndrome, where a decreased amount of cortisol would be due to adrenal insufficiency or Addison's. So what can cause an excess cortisol level? Well, a tumor of the pituitary gland, or a tumor on the adrenal cortex, or the excessive use of cortisol or some other similar corticosteroid hormone that is used for the treatment of life-threatening illnesses can cause Cushing syndrome. And the characteristic changes include a metabolism of carbohydrate, protein, and fat is disturbed. Your blood glucose levels will tend to rise. Protein synthesis is impaired, so the body proteins are broken down. It leads to loss of muscle fibers and muscle weakness. And then your bones will become weaker and more susceptible to fracture due to your body kind of pulling the nutrients out of your bones. Patients may also experience some weakness and fatigue, depression, mood swings are common, increased thirst and urination, high blood glucose levels, weight gain in the abdomen, the face. They may develop a moon face appearance with Cushing's. The neck, upper back, they might get a buffalo hump, as I talked about in the very first video on the endocrine system. They could have thinning of the skin, which will cause easy bruising, pink or purple stretch marks known as striae throughout the skin. Increased acne, facial hair growth, and scalp hair loss in women, and cessation of your actual menstrual periods. It also causes darkening of the skin, which is called acanthosis, and on the neck is the most common place you might see it, and then obesity of poor growth in height in children. Obesity and poor growth in height in children are very common as well with Cushing's. Again, this is a hormonal issue. All of your endocrine emergencies are. With Cushing, you see a lot of these hormonal changes. Pre-hospital management is going to be mostly supportive. Assess and manage the airway, breathing, and circulation. Manage life threats immediately. And you're going to generally be supportive in your care, providing an IV, O2, and some monitoring. Obtain blood glucose levels. And if indicated, you're going to want to manage those blood glucose levels as well. Next up, we have an adrenal gland tumor, which is called pheochromocytoma. Pheochromocytoma, which is a rare condition in which a tumor, usually in the medulla, causes excessive release of the hormones epinephrine and norepinephrine. Remember, the inside of the adrenal gland has our adrenaline and our noradrenaline. So when we have a tumor, we could have an excess amount of those hormones being released. Less than 10% of them are malignant, so they don't metastasize into other parts of the body. And most common in young adult to mid-adult life. Young adult to mid-adult life. And the combination of symptoms that are frequent but sporadic is common. It may increase in frequency, duration, and severity. And of course, you can just imagine the symptoms are due to the increased production and release of epinephrine and norepinephrine. So increase in motility, heart rate, diaphoresis, all of these things can be an example of some symptoms that somebody with an adrenal gland tumor might present with.